This conference will now be recorded.
Hello, everybody. Welcome to the webinar on artificial intelligence in medical technology. It's a great pleasure for us that we could reach so many participants that are interested in this topic. We are also happy that we could win 3 experts of this powerful technology. My name is Clara Altin-Toprak and I will moderate the session today. Before we start, I would like to outline some rules for this webinar. So please switch off your camera and also your microphone. And during the whole webinar, only speakers will be allowed to talk. So if you want to ask questions, please use the chat function. And if you cannot hear the speaker, please inform us via the chat function or alternatively use the dial-in number. Now we come to our agenda. First, I will give a short introduction on the S3martMed project. This was followed by the presentation of Professor Gabriela Balestra. She will present artificial intelligence in medical devices. Then Damien Bertrand will give a talk on DNA analytics and data science expertise for the healthcare sector. And finally, Johannes Stelzer will give a talk on artificial intelligence in imaging. At the end of the 3 presentations, we will read out your questions and the experts will answer them. So now to the S3martMed project. What is this project? This is a new European initiative which is supported by the COSME program of the European Union and was launched in October 2018. The project is organized by 5 cluster organizations in Europe, which are dedicated to healthcare and medical technology. Our ambition together is to boost scientific and business collaboration between small and medium-sized enterprises and research and technology organization in the medtech area. And we want to encourage the most promising collaboration ideas to become projects thanks to tailored cluster advices in collaboration with our regional authorities and the European Union. To identify synergies and generate collaboration opportunities in medical technology, we have different activities in the years of 2019 and 2020. First, we have organized 3 different webinars, one on the new MDR, then on 3D printing, and the webinar today on artificial intelligence. You can have access to the webinars also via our S3martMed website, where we have the records. Further, we provide tailored business and innovation advisory activities for high potential identified project ideas and support for funding schemes. Furthermore, we have 2 interregional networking events. The first one with the title SmartMed Needs Smart Tech takes place in September 19th to 20th at the University Hospital in Tübingen, Germany. What will you expect? There will be live surgery sessions where clinicians present their challenges and needs related to medical technologies and real conditions. Further, there will be keynotes on 3D printing and artificial intelligence, and you can also meet face-to-face via pre-arranged meetings. The registration is now open, and for the registration, please visit our project website. What will you expect? So there will be face-to-face meetings to find collaboration partners and get new ideas to develop medical devices, for example, surgical instruments, or in the area of 3D printing and artificial intelligence. How can you profit from this event? In case of the surgical instruments, you get detailed insights and problems clinicians are faced during synergies, and in the 3D printing workshop. Excuse me, there's one microphone not muted. And during the 3D printing workshop and artificial intelligence workshop, you can initiate collaboration with 3D printing and artificial intelligence experts. Furthermore, you have the chance to meet manufacturers and service providers from different European regions. And there will also be advices in funding and investment, so how to finance your collaboration projects, especially the interregional projects. At the first day, there will be a live surgery. So this is in September 19th. There are 4 different topics, one on heart surgery, as an example, the implantation of an artificial heart, or surgery of the pituitary gland. Further, there are adjustment of a 3D printed epithesis, and also the surgery of a pelvic surgery with neurostimulation. At the end of these 4 live surgeries, you have the chance for face-to-face meetings with the clinicians, other small and medium-sized enterprises, and also research and technology organizations. This day ends with a get-together and a barbecue. On the second day, there's a workshop on 3D printing and artificial intelligence. So first it starts with 2 keynote lectures on these topics, given by Patrick Springer and Johannes Horsch, as well as Dr. Johannes Stelzer. And this is followed by a pitching session where you can present your needs and offers. And then it will be also supported by funding and investment advisors from Hitcham, Abgay, and Hartmut Welbeck from the Steinbeis Europazentrum and André Zimmer from the Association for Business Investment. Further, you can pre-arrange face-to-face meetings by the B2Match platform. For registration, you can here visit this platform. So thank you for your attention, and now we will start with the first talk. So this is given by Professor Gabriela Balestra, and she will present artificial intelligence on medical devices.
Okay.
So we are waiting until the screen is shared with you.
Is it shared? Do you
You
see
have
my
to
screen?
accept. No, not.
It's coming. Yeah, it's Emily
coming?
speaking. Yeah, it's coming. I think
Okay.
I give you the screen. Normally it's coming.
Okay. So let me know when I can start.
Yeah. Have you received the request?
Oh, no.
Normally I send it to you.
Okay. Okay, so now the presentation. Is it okay now?
Yes.
Perfect. Okay, so good morning to everybody. I'm Gabriella Balestra. I am a professor of Politecnico di Torino in Italy. And my talk today will be about artificial intelligence and medical devices. The presentation will be divided in two parts. In the first part, I will go through a very brief history of the application of artificial intelligence, starting from the 1950 and arriving today. And then I will just show you some of our application in the field. So let's start really with what I call a dream. The dream is to have machines that do things like humans do. And it's a dream that started as soon as computers were born. So as soon as we had the computers, also when the technology was really less, with very less performances, if we compare them of the performances we have today, people started trying to put intelligence in the computers. But first of all, we needed to assess if a computer system, a computer application show an intelligence behavior or not. And usually we refer to a test that was proposed by Alan Turing, that I think is well known, a researcher, in 1950. And Turing just proposed to have a person in a room, and in another room, either a person or a computer system. And he said that if the person in the first room is not able to understand if she is talking to a person or to a computer, then and is talking to the computer, obviously, and in this case, the computer system can be related. It can be said to have an intelligent behavior. Really, artificial intelligence is a term that was first proposed by 5 researchers in a proposal of a 2-month, 10-man study in 1955, and then they showed the results in 1956. That is generally recognized as the official birth date of the new field, but now is not so new. Then we have the application of 70s and 80s that were mostly expert systems. The idea of expert system was to separate the knowledge from the computer instruction. So the researcher wanted to construct systems based on expert knowledge extracted by a process of elicitation. And they usually represented the knowledge with rules, means a construct that is divided in two parts, an if part that is called the antecedent, and then the second part that is called the consequent, and it's a conclusion or an action. And we still use rules in some of our applications today. Okay, the new, what we can call the new era of AI started at the beginning of the century. We can see here that starting from 2000, we have a very big increase of papers on artificial intelligence in general. And the source of this is Scopus, that is a very well-known base, bibliographic base. And also in the specific field of medical or health, we can find an increase of papers starting from 200 papers a year before 2000 and arriving here at 2,600 papers in 2010. If we want to define artificial intelligence, it's not so easy. You don't find definitely only one definition of artificial intelligence, but we can say that if we think of artificial intelligence from the computer science point of view, we say that this is a branch of computer science dealing with the simulation of intelligent behavior. If we look at it from the side of intelligence, we can say that we want a machine that imitate intelligent human behavior. Okay, so now in this new, what we can call this new era, we changed also the way in which the applications are constructed, because now we usually extract knowledge directly from data, very big, large data set of examples, and not anymore from experts. It was a very difficult task. The methods are usually grouped according to a big area that is called machine learning. And in the last few years, we have a very spread of applications that use deep learning, as we can have a very large number of examples. Among the methods, I think the most popular are for sure neural networks, but also decision trees are used, and their assembler, that is a random forest, and fuzzy logic, but also a lot of other methods are available. Let's say that the applications are maybe used in all the clinical practice, starting from the process of diagnosis, that sometimes is a very hard process, then treatment, either the definition of a treatment or the evaluation of the results of a treatment, and also patient monitoring, that is the main activity of most of telemedicine applications. Among the possible paper that you can find in literature, I selected this recent review that was published this year. and because it's a very a complete review according to me, and the author said that she identified four main distinct ways in which AI is being employed. First, in the assessment of risk of disease, that is a very important problem today, and in estimating treatment success prior to the initiation of the treatment itself. In an attempt to manage or alleviate complications, to assist with patient care during the active treatment or the procedure that phase, and in research. So if you look at the area of application, we found, as usual, cardiovascular as the area with a lot of application, maybe the one with the major number of application. In this case, I just reported from the same review, the two example using neural networks. The first is to predict the risk of congenital heart disease in pregnant women, and the second one, diagnosis coronary artery disease. But also there are a lot of machine learning application for cardiovascular disease risk prediction to diagnose patients with different kind of diseases. Then the other important area of application is for sure oncology, in which I think the most important application are the CAD systems, where CA is for computer aided, and the D sometimes is detection, sometimes is diagnosis, sometimes is design. It depends on what we are constructing. But anyway, these kind of systems are used to help detecting tumors, to store their malignancy, to evaluate the response of neoadjuvant therapy, to evaluate chemotherapy, and a lot of other applications, usually based on medical images. But also with sometimes using both medical images data and clinical data. Then we have a lot of application in very different areas, so I decided just to put four of them just to give you an idea of how different can be. The first one is about respiratory virus. The second is about the identification of depression, so in the psychiatric area. Then the third one is to translate brain waves into speech to help a patient who are unable to talk, and then to select among different treatment alternatives the alternative that is the best one for a specific patient. Okay, but a problem arises, and there are a lot of discussion on Twitter or on other important platforms about the reliability of AI. So I go back to 2000 when there was a report that was titled "Where is Human?" And in the report was stated the importance of designing systems that make it hard for people to do wrong things and easy for people to do the right things. So what we want is to have reliable systems to help people not to do wrong things. And this is something that is important in general with AI systems. I think in the field of medical devices, we have also a normative that is in some way also to be applied to AI systems. Really, we have now a directive that will be replaced in 2020 by the new regulation. And this regulation has a specific highlight on medical device software, and obviously we should also think that AI systems are mostly software, so we need to understand how it will influence the application of AI systems. I think the regulation is important because it's a way to assess the safety of an application for the patient and for the operators. Okay, let's go to our work. We work in two main areas. The first one is biomedical signal interpretation, and the second one is radiomics. Among the application of biomedical signal interpretation, I have chosen this problem about to detecting and interpret the EMG activation during gait. So during gait, we have muscles that are sometimes active and sometimes silent, just to help the biomechanics of the movement. So what we do is, as you can see here, we just identify the range of samples, so the time in which the signal is active, the muscle is active, so we have a signal, and we just call on the initial of this window and off the end of the window. If we look at a walk of, let's say, 2 or 3 minutes, that is what we usually do, we can see that we have very different activation intervals. So if we just want to represent the behavior of a single muscle during gait, and we just take all the on and maybe just compute the average and standard deviation, we will have a standard deviation that is very high. And this is because really we have different behaviors of the same muscle in different strides. So what we did was to use the hierarchical clustering just to understand these different activation modalities. And as you can see in this picture, you can it is clear that we have at least very different activation intervals. So if we look at the on and off average in a cluster, the standard deviation is very small, meaning that in those three strides, the behavior of a muscle was very consistent and similar. Okay, this is one. Then we have, I selected 2 radiomics application. The first one is a CAD system for the identification of prostate cancer. And in this slide, you will see all the process from the acquisition of MRI images, then feature extraction, that is usually performed in ROE, and extracting different kind of features. In this case, we were 16, but in other application, we have several hundred of features. Then usually we need to understand which features are really important to the classification, and we use feature selection for this identification, because feature selection maintains the features that we have extracted. So it's easier to interpret the results of the classification from kind of feature, and also the feature selection in this case is show information. In this case, we use the method for feature selection that require the discretization of variables, and for that we use the chi-square algorithm. Sorry. And voxel classification that was performed with a software vector machine, and then with some post-processing, we were able to identify the tumor. Then the other application is the identification of active bone marrow from the CT scan. In this case, we still perform feature extraction. Then it was very important, the training set construction. So we just used the 5 slices for each patient, all the slices, and we used as a classifier the 3 classifier. As you can see, these are very preliminary results. We have 2 areas that are with very good results, and one that is less good results. Really, these were results presented in a conference in October 2018, but we have now better results using neural networks that will be presented in the next conference. Okay, just to go to conclusion, let's go back to a dream. Will it come true? I don't know. For sure, I can say that applications that use AI are now possible and are now used. And we can say that the computers are for sure faster than humans to perform computation, but the humans in most cases are still better in the generalization use of their knowledge. So we need to work still a lot to have a reliable AI application. Thank you for your attention.
Thank you very much for this clear and informative talk, Gabriela, and how you estimate artificial intelligence and how it can be used in medtech area. And now we come to the next speaker, Damien Bertrand. He will present DNA analytics, data science, expertise for the healthcare sector. So please, Damien, could you go on? So there's something wrong.
Do you hear me?
Now we can hear you, yes. Thank you.
Okay, there was a problem, sorry. Good afternoon, everybody. I'm just sharing the presentation. Okay. Do you see my slides?
No, not at the moment.
Okay, sorry. Now you see my slides?
Yes, we can hear.
Okay, very good. So first, thank you for giving me the opportunity of presenting what we are doing at the Analytics. And I'm quite grateful to present just after Gabriela, because she has presented not only the historical context of AI, but also a number of interesting aspects related to the different algorithms that prove useful in healthcare context. So first, a few words about the Analytics. We are a startup company that was founded a few years ago. We are almost 10 people working now within the company, and we apply a variety of data science technologies exclusively in the healthcare sector. I will, of course, provide a number of examples. So we can distribute our activities and projects in three main categories. The first one is the one we call research or clinical research, and encompasses a number of projects that span all the way from preliminary research, drug development, drug discovery, the preliminary research before developing medical technologies, down the road up to the development of techniques that prove useful in clinical workflows, meaning for clinicians and for patients. The second sector of activities relate to biomanufacturing. We analyze the data that are being produced in the processes for producing biological drugs or vaccines, for example, and we help performing models over those manufacturing processes and supervise the production of the next batches within the production plants of the biopharmaceutical industry. I will, of course, give you some examples. And the last sector of activities is public health, meaning that we can also process registries or aggregated data representing healthcare in a given context, given geographic area, and extract some features or some observations that may help taking decisions or orienting healthcare policies at a regional or local level. If you like beautiful logos and pictures, you'll like that slide because it represents a little bit the overall set of partners and topics we can cover. First, it's important to understand that the analytics is able to work with any kind of data. So, of course, given the name of the company, you would suspect that we work with genomic data, which is true, of course, but we can also incorporate other clinical data, biological data, reported data, and even psychometric. I will give some examples and put all those data together. And I would highlight that one of the features of the analytics is the capability to develop data models that are able to handle multiple sources or multiple natures of data into a given model. We do that over a variety of therapeutic areas. So as you can see in the second round, we had experience in projects dealing with allergy management, cardiology, urology, oncology, and a variety of context, and also a variety of stakeholders, partners, of course, involving biotech and pharma companies, but also providing support to contract research organizations, CROs, that are typically those running the clinical studies. We help them providing data analysis beyond the standard bioinformatics. We work also with lab and research institutions as well as clinical institutions. If I want to highlight a little bit what are the specificities of the analytic, I would say first, even if we are able to handle big data, which is very popular in the news and in the social networks, we are, I would say, specialized in different data sets, and especially the life science data sets, which are typically constituted of rather few number of observations, few tens or hundreds of patients, let's say few tens of production batches in a manufacturing plant. This is quite a small number compared, for example, to the number of registered users on Facebook. Facebook is very brilliant for applying big data because you have millions of individuals. In a clinical study, you have maybe 100 or 200 individuals, and you have plenty of variables describing those individuals, inducing very broad and low depth matrices of data that needs to be handled for extracting meaningful information. This is a specialty for which we have developed specific models. In terms of how we work, typically we use the R framework, which is very popular in bioinformatics, and we use it with a number of libraries that are provided and available. This is essentially open source technology that we use on a day-to-day basis. This is complemented on the second row by routines or modules that are being developed within the analytics, which are most of the time kept as internal technology. In some situations, we share those technologies back into the open source community. That's the example of the WEBINAIRE module, for example, which is open source available, but which is still maintained by DNalytics. In most other contexts, we develop these libraries and we maintain them in an internal toolbox, which allow our analysts to be performant and to have the right level of expertise when dealing with the different projects. And depending on the expectations, we may bring a third layer of development, which is the encapsulation of these routines and modules or models into custom applications that are being rolled out to the partners for routine use. This is something that we do typically over proprietary data sets. So typically a partner comes to us with a quantity of data that needs to be analyzed. In some situations, we may complement data sets with external data sets that are publicly available, like those quoted in the bottom of that slide. I will now provide a few examples without entering into the details, which sort of highlight the kind of expertise we have at DNalytics. First project on the left-hand side is a project which was developed for clinicians in a Belgian hospital. The challenge there was to anticipate the development of adverse events in the case of pediatric issues, and the purpose was to try and prioritize these kids with respect to the need to liver transplant. We have not only developed that model on the basis of clinical observations and a number of biological markers that are typical of blood drones that are being applied to those kids, but this model has been encapsulated into a web platform which is now used by the clinicians on a daily routine. On the right-hand side, this is a completely different project. This is a project developed for a Belgian company producing medical device diagnosis technologies. In that situation, they were willing to develop a test to qualify specific mutations in a given gene associated to blood disorders. As you can imagine, it's impossible to score from a given test all possible mutations over one gene. So we help them identify those mutations that are correlated to specific pathogenic developments and translate those mutations into their test, which is now available commercially. The third example is interesting because it highlights a completely different sort of data. In that project, the purpose was to characterize the exposition of individual patients to the placebo effect. You may know that when you have a multi-arm study, in some situations, it's important to know whether the patients will develop a placebo effect against the drug to qualify the effectiveness of the drug. Placebo effect, the way the people react to these drugs is something that you cannot control, but we have developed a questionnaire to sort of rank the patients according to their personal experience of the placebo effect. And on that basis, given the fact that it's not possible to take out this exposition for the patient, we have proposed to that partner a methodology for distributing homogeneously these patients among the different arms of the study in such a way that this placebo effect does not constitute a bias in the analysis of the results of the clinical study. The last clinical example I will describe is attached to the management of food allergies. This is a project with an American company developing an immunotherapy against peanut allergies. These typical drugs are complex because they need to be taken for 12 to 18 months before one can say that the person is desensibilized with respect to the peanut allergy. They had two questions when coming to us. First was to see whether at the very beginning of the treatment there was a possibility to identify a response to the drug to encourage the patient and the clinician to continue over the 12 to 18 months. And the second question, which is still an investigation ongoing, is to see whether one can predict the level of desensitization after the treatment with that specific drug. All those examples are just a subset of projects that we had at DNalytics and highlight the diversity of the markers, the models, and the context in which our tools can be used. I was mentioning about public health. I will not drill down very deeply into that project, but just looking at the map depicted on the slide, you can see that in that specific context, which is related to the management of rheumatoid arthritis patients in Belgium, there is a large heterogeneity in terms of the prescription of the drugs to treat those patients, and this is relative to the number of patients, meaning that it highlights difference in the practice over the different provinces. This is kind of investigation which is worth for discussing with public health management system and see why these are so important differences and how we can streamline and homogenize the clinical practice over a given territory. And the last topic I will address is the management of biomanufacturing. This example relates to the production of a specific vaccine, and the challenge for us was to integrate the dataset coming from a large number of different environments, the management environment in which the raw materials are being stored, the laboratory tests that are being performed by the QC department, all the data measured over the reactors during the production, and so on. Our role was to integrate all those data into a sort of data lake, I might call it, and to produce a digital twin of the manufacturing process from which we have been able to identify recommendations to enhance the quality and the quantity of the production of the produced vaccine. You can imagine that this is essential for the firm to be very efficient in that production of those vaccines. Not only we can perform those retrospective analysis over available data set, but when this digital twin model is available, we can integrate that model into dashboards or software interfaces that can be used prospectively on the daily routine to monitor the production environment, to extract the performance, or to anticipate possible deviations with respect to the normal behavior. I will not provide additional examples, just to mention that typically we work in a project-based modality, so to say sort of a consultancy. We come following the request of a partner and we deliver a given result. In one situation, we have been able to proceed into a product model, meaning that we have industrialized a model which is now being used in rheumatology to diagnose specific sorts of patients and to provide guidance to the selection of treatment. This was an exploratory project with academic partners, but the analytics has taken a sort of license over the IP of that project. We have industrialized that technology, registered the technology through the CE marking process, and it's now being available for commercial use in the rheumatology clinical departments. So to end up, I will highlight the two typical models through which we are working. As I was saying, typically we work on a project base, meaning that we come as experts for a given mission and we deliver a report or an analysis, a piece of software according to the expectation of the customer. But we can, in some situations, have a more long-term relationship, develop together with our partners softwares that are incorporating data science, machine learning technologies, and work through licensing model on long-term relationships. That's all I would say for now regarding the analytics, just to say that the company is really good in terms of growth and performances. We believe it's very important to provide qualitative service, qualitative expertise to our partners in a quality framework which is compatible with medical device and medical technologies, and we highlight the willingness to partner with our customers to extract the best out of their data. And with this, I thank you for your attention.
Many thanks to you, Damien, for this, for presenting the activities of DNAlytics and giving so many example projects of your work. And now we come to the third talk. This is given by Johannes Stelzer from, he will talk about artificial intelligence in imaging. So, Johannes, could you please go on.
Me? Ah.
Okay, now we can hear you. Okay, perfect.
Okay, then I can start. Yeah, my name is Johannes Stelzer. I'm currently a researcher at the Max Planck Institute for Biological Cybernetics. I've been primarily working with ultra-high field magnetic resonance imaging. But a few months back, I have founded a company with two colleagues, which is called Colugo. And our mission is to bring cutting-edge AI methods to application in industry. Today, I would like to talk to you a little bit about our point of view from artificial intelligence within medical imaging. And to give you an overview, the outline of my talk will be, I will briefly give you an overview about medical imaging and AI. So principally, why is it actually relevant? And very briefly also, what is this form of artificial intelligence that most of my talk is focused on, namely deep learning. In the first part, then I will give a couple examples how artificial intelligence can assist the analysis or interpretation of medical imaging. In part two, I will briefly talk about how AI can be used to improve imaging quality. And in part three, how AI can help to actually develop new acquisition methods. And with that, I would want to come to the motivational slide here. This is a study from McDonald's and colleague from the Mayo Clinic in Rochester, USA. And they basically crunched the numbers in, for exams for radiologists. You see here MRI, CT, and CT plus MRI, all collected over the years. And what you can see here is that those numbers are rising, continuously rising. And if you look at the right chart, the total number of images that are interpreted each year, that's even rising further, meaning that nowadays a radiologist typically acquires multiple images simultaneously that are then used for examination. And the authors here in the study come to a very interesting conclusion, which for my gut feeling is already a little bit tough, because they say that on average, radiologist now has to interpret an image every 3 to 4 seconds in his 8-hour shift. So that is very extreme from the numbers I've heard so far here in Tübingen. It's rather a couple minutes, but nevertheless, the pressure is there, and the fundamental idea to use AI for assisting the analysis and interpretation is that certain aspects of this job can be accelerated and made easier, so the radiologist can concentrate on other tasks that bring more value. Very briefly about the deep learning ideology also here. The way that it works traditionally is depicted in this upper box here. In the upper box, we have some imaging modality, let's say lung cancer, and the radiologist or doctor looks at it. He looks at the texture, he looks at the distribution of values, he looks at the shape of values, and takes together his year-long practice and knowledge to form an idea of what this is, what he's seeing. The fundamentally different new approach that is brought with artificial intelligence works the following way. Instead of handcrafting what you have to look for, so a certain texture, or a certain histogram, or a certain shape, you feed more or less the raw data into a computer system. Here in this case, in imaging modalities, this would typically be convolutionary networks. So we feed the data in there, don't do any feature engineering, so don't manually extract anything that the network looks for, but rather take a lot of data, really a lot of data, so the neural network can automatically learn to look for the important data characteristics. So you see, instead of really teaching the network what to look for, we let it automatically learn these properties from the data itself. This is a shift in ideology. that has started a couple of years back. And here you see a temporal overview. So you see that this deep learning is really starting to hit medical imaging, starting 2015, 2016. The numbers now are of course much higher, but you can see the main task that deep learning is here used is segmentation, detection, and classification. The main modalities are MRI, microscopy, and CT, and usually it's for pathology or particularly in brain or lung. So far, that was the overview of AI in medical imaging. Now I would like to dive into a couple concrete examples and walk them through with you. We group them according to certain groups. So the first part is just about how artificial intelligence can aid the analysis and interpretation side. The first study I want to show you is actually an almost historical one. That's the study from the group of Jürgen Schmidhuber from Switzerland back in 2013. This was a key study for the case of deep learning for segmentation. Here in this case, it is about mitosis detection, and mitosis is a very hard problem to detect. So what you see here in green, this are the true positives, these are the true cases of mitosis. What you see in red are false positives. So you see, if you would want to really engineer a software system that tries to look for these dark spots and detect them as mitosis, you will run into a lot of problems, because all of this here is mitosis free. This is not mitosis, but it looks like. While this also looks like mitosis, and it's not. So it's a really, really hard problem, and they solved it with this deep learning approach that I just briefly sketched out. They used convolutional networks and a lot of data, and the networks, they operate on the raw data, on the raw RGB sample data, from a square patch of the source image. And the study is so relevant because they massively outperformed all other automatic analysis that had been there before that used this handcrafted feature selection. So this is one of the papers that really started the deep learning revolution. Now coming to a different study where it's about prostate cancer. So we have the so-called Gleason score, which helps you to rate the prostate cancer and also to decide on the further going treatment options, and it's heavily subjective and based on microscopic images. And here in this approach, Nagpal and colleagues have quite recently trained also a system using convolutional networks and a big data set. It actually consists of 112 million annotated image patches from more than 1,000 slides, and they trained it on this big data set, and they achieved something that I think is quite remarkable, namely superhuman performance, because they had the ground truth. They knew what was the good score, what was the right score, and they could train the system. And you see here the different pathologists and their accuracy ranked according to their accuracy. And actually, there's just two of these pathologists that perform better than this deep learning system. So you can see in some limited scopes, these deep learning approaches may achieve even superhuman performance. This example is about spine metastasis. Is actually very similar, just a different image modality, and you can also see how just for you to see how difficult this task can be for untrained human to really detect the difference here between the true positives and false positives. And this deep neural network trained by Rothhead colleagues also managed to have a very good performance here for the true positives and detecting the false ones as well. Another very different application, how here is an image retrieval application. Let us assume that we have a very heterogeneous medical imaging database. and then Cetran and colleagues, they trained autoregressive model. This is actually not directly deep learning based, but related in some way. To do the following, you give an image query. So this is an image that maybe I just acquired from a patient. And the system automatically, just based on the image itself, not on the metadata, then gives me images and therefore also cases where we have a similar medical finding. And you could see how this can be a very useful tool if I really want to pull up similar cases of some imaging that I just see now. I could really drastically increase my capability to detect various diseases. Okay, so far to the first part. Now I would like to come to the second part here, which is how artificial intelligence can be used to improve the image quality. And the classical example that always should be brought here is the so-called denoising problem. Here we have a fairly recent study from Manjan and colleagues who used magnetic resonance imaging. And what you can see here on the left is a slice, sagittal slice, and you see the corny structure. I hope the resolution of this webinar is good enough so all of you can see how corny this image on the left is and how nice and clean the image on the right is, in the middle is. And this is our input image, and this is the final image after denoising. So in this case, a deep neural network was trained to not only detect the noise in the image here, but also to remove it, to in-paint it. And this remarkable trick can be achieved by feeding neural network images and artificially adding noise to them and overtraining them. The neural network can understand to remove this typical noise that you also added during training, which you can also see here. So this would be the noise structure that was added here. And the same also works for T2 weighted images. You see it's also a little bit corny here, particularly around the brainstem. You can see that nicely. And it's really cleaned up here quite a lot. So this is a classical case, I would almost say, where AI methods can be used to improve the image quality. Another very famous example is the so-called super resolution example. What we have here is also the basic problem is what we want to have. We want to have algorithm, a deep neural network that we put in an image of a relatively poor resolution and we get out an image of a better resolution. And this can be achieved in a similar way by undersampling the image. So this is the original image here in A, and it's being downsampled. This is how it looks like after it's being downsampled. So this is the input image for these various algorithms and the deep neural network. And if you sample it up by using just simple bicubic interpolation, it of course looks a bit better than this nearest neighbor interpolation here, but still by far not as good as the original image, while this is the approach that is here proposed by Chen and colleagues using deep neural network, which gets, if you really compare these two, really gets a lot of detail out here. That information that principally was in here, so you can also see it in this downsampled version. That it's kind of, you can see that this kind of patch here, this darker region in the middle, it might indicate that this structure here was actually hidden beneath, and the neural network is able to understand that and basically pull that out of the data. So super resolution is also another important, interesting method to improve the image quality. So you could theoretically simulate a scanner with a higher magnetic field. Furthermore, this is one more example. It goes a little bit farther, and it's than the other ones. What we have here, this is just very, very briefly, are generative adversarial networks. They're coupled together. These adversarial networks work the following way. You put in an input vector into a generator network that folds up this vector and generates an image out of the nothingness, basically. It has learned to generate images. And this technology is already around a couple of years now. Being used to generate faces and so on and so forth. But the interesting part is if you couple two of these generators together, you can achieve something quite remarkable. Namely, you can make a translation from one image domain to another one with the same image. That is not possible. And you might ask yourself, so why is this relevant? This is the important case here that we derive here. So it's the scanner variability. Here we have the same subject, left and right. It's being scanned with different scanners. Yeah, but it's the same brain. And naively, you might expect it should look the same, but it doesn't, because the sequences might be different, or the coil might be different, or there's a different shimming, or a lot of reasons why it could look different. And but it should look the same, particularly if it's not a radiologist that wants to do this comparison. But if we think of scenarios like a study where we want to investigate how a patient develops over time. Another important scenario here would be if we want to use automated methods to, for instance, derive the cortical thickness, or to do a segmentation into brain areas. Then we really want to make sure that the same subject gets the same pixelation and the same values, irrespective of the scanner that we use. So with this technology that I showed before, this image-to-image translation, it's principally possible, and this is something we're at the moment also working together with the client to make a translation from one scanner to another scanner. So we have a standard reference scanner system, so to say, image system, on which we can train the algorithms, and then we can deal with this heterogeneity that is otherwise introduced. Okay, now we come to the third part of the talk, which is also the shortest part of the talk. And I actually just want to show you one example for AI-driven image acquisition, because already at the moment when we acquire images, here in the case of magnetic resonance imaging, we can do something interesting. Namely, what we can do is we can not sample the full K-space. So this is basically acquisition space of MR imaging. So instead of sampling this full K-space, we massively undersample it. That means that our time for acquisition goes down a lot by a factor of 2, 3, 5, 10. And also the energy being deposited goes down, which is always great. But if we do something like that, then the original image that would look like this suddenly looks a bit like this, which you can see is a little bit corny and has a couple artifacts in it. And the question is, could you on acquisition side, if you acquired an image like that, interpolate basically this missing K-space lines and reconstruct the original image as it would have been if you had acquired the full K-space? And that can be answered with a careful yes, this is possible for this type of images. So you can reconstruct these images out of the heavily undersampled K-space. But this is basically just one application. There are many going this direction now to really accelerate the imaging, to just image what is really, really necessary and reconstruct the rest using deep neural networks. And that, of course, opens the horizon to much shorter scanning times and or much better resolution. So this is already my last slide, and I would like to thank you for your attention.
So thank you very much, Johannes, for your presentation and how artificial intelligence can be used in medical imaging. So as far as I can see, there are no questions asked by the chat function. Emily, could you confirm this?
No question.
No question. So so then I want to thank all the speakers again and all the participants for listening to our webinar. And now we will end this webinar today. Thank you and goodbye.